Good afternoon, everyone. My name is Lexi Weiberg, and I am the Manager of Provider Success here with Premier. We are going to give you some information that has just been released from CMS and about new rules regarding telemedicine and some different updates. Crescent Beavers, our risk adjustment coding manager, is going to be going through different codes and things like that for y'all. If you have, I'm going to have everyone muted during the session. If you have any questions, you can put them in the chat and we'll answer those at the end. And then we'll also open it up for questions at the end as well. So we want to be able to answer all of your questions. And if you have a question, it probably means someone else has a question about the same thing. So please let us know. We're here to help. And so we will go ahead and get started. And like I said, just put any questions you have in the chat, and then at the end we'll go through and answer all those questions.
Good afternoon, everybody. Like Lexi said, I am Crescent Beavers, and I am the Risk Adjustment Program Manager. I know that everybody has lots of questions, and we're hoping that we can answer some of those questions for you today and start moving forward through this process of these big, hard changes that everything is happening with right now. So what you can expect coming from us is we are currently in the process of building a communication platform. We'll be able to communicate the most up-to-date information as it comes in, give you some practice guidelines, billing, diagnosis codes, and CPT codes, things to ensure the continued revenue into your office. PBEs are going to continue to keep in contact with their providers via the GTM meetings, emails, and telephone calls. And as always, all the Premier staff is available for questions and guidance as we move through this hard time. So these are some of the things that we are going to be releasing in our communication platform. This is a billing tip sheet that we are working on. It is an evolving process as rules and regulations change. We had one built out, and the next day everything changed. So with these platforms, we are hoping that we bring all of you the most up-to-date information as we receive it, and giving you the most clear, concise information that we can present to you from CMS, the payers, from the CDC, those kinds of things. So the biggest question that everybody has right now is the telehealth services and what services are available, what we can do, what we can't do. So with this billing tip sheet that we have made, it kind of goes through all of those codes that you can bill out, what modifiers that you need to have, what are the regulations that go along with those, what means of communication or technology are required for each of those. So we'll start with the first one, your telehealth visits. That visit is a telecommunication visit between the provider and the patient. The common telehealth codes that are billed out are just like a sick visit E&M, the 99201s through the 215s. You can continue to bill out your transitional care management visits. Your annual wellness visits can be done. We understand that with these annual wellness visits that not all of the key points can be addressed, like their vital signs and your dementia screenings and some of those things. But you can go through and still do those. And as long as those are documented in your chart appropriately, those measures that we cannot meet with the telecommunication, we can always, after hopefully this crisis is over, bring our patients back in to gather those measures. We still have plenty of time in the year to make sure that all of those measures are met. Place of service codes for all of these visits will be place of service code 2 for telehealth services if they're provided via one of the technologies that are listed in these categories. We can do new patient visits and established visits on these telehealth visits. Synchronized virtual visits are real-time audio visual platforms need to be built out with the modifier 95 on them. And then you get down into the e-visits, which are your visits that are through your patient portals in your EMRs. They are time negated. So we understand that with these visits, you cannot meet all of the components that are required for E&M documentation. But with the time negated codes, those measures do not necessarily all have to be met. With the e-portal visits, those are reported once in a 7-day period and are accumulated over that 7-day period time. So if in a 7-day period you have spoke to the patient, done email communications, text messages, video conference calls with those patients, you want to do those as a lump bill and not at each visit. So if you spend 5 minutes with that patient today and another 5 minutes tomorrow and maybe 7 minutes the next day, then you would want to choose the appropriate code for that 7-day period. For your virtual check-ins, these are your brief telephone calls, audio calls that are for patients that are calling in that need refills on their medications. These are very brief check-in calls with the provider, 5 to 10-minute conversations that don't require any extensive visiting with the patient. Just, hey, I need my refill on my meds, and you can bill out these codes, the G2010 or 2012. The diagnoses that are listed, these are extremely important in the aspect of the tracking purposes for the CDC and for CMS to ensure on certain policies and plans that when claims do get processed, that they are processing claims that are related to COVID-19 in the appropriate fashion for patients' copays, deductibles, and coinsurances. Some plans are waiving those, some plans are not. We advise that on all commercial plans that you are verifying benefits with these patients. Some do have telehealth services for outside of this emergency situation, some do not. For your CMS Medicare patients and Medicare Advantage patients, everything is covered for these patients, but making sure that we have the appropriate diagnoses listed is going to be crucial for tracking those purposes. So if you have possible exposure, use the appropriate code for that, confirmed exposure. If you have patients that have signs and symptoms of the COVID-19, but you do not have a confirmed case of just billing those signs and symptoms. And then the patients that do develop the pneumonia, acute bronchitis, lower respiratory infections, or acute respiratory distress syndromes, that you bill along with those the COVID-19 diagnosis and only bill them if they are confirmed cases due to the virus. That code for the COVID-19 is the B97.29. Those have to be billed in conjunction with the confirmed diagnosis and due to the COVID-19. Some things to note, information that we are giving you here today applies to all your Medicare members. That's your Medicare Traditional and your Medicare Advantage. For commercial and Medicare Advantage members, like I said, you want to make sure, and especially on your commercials, to verify those eligibilities as needed. standard E&M documentation applies. The only thing that you need to make sure that we are documenting in these notes for your telehealth services is your start and stop times must be in your note to indicate the time spent so that the appropriate codes are being billed out. No authorization is needed for your COVID testings. All copays for COVID testing and telehealth services have been waived. The use of telehealth does not change the out-of-pocket costs for beneficiaries. Beneficiaries are generally liable for their deductibles and coinsurance. However, the healthcare providers are allowed to reduce or waive these cost sharing for telehealth services. That is up to the healthcare provider. All HIPAA violations at this moment during this emergency order have been waived. So if you only have a way to communicate with your patient via FaceTime, Skype, Zoom, any other kind of video conferencing platform, they are not going to issue any kind of penalties for HIPAA violations for that. And they have also said that they will not be conducting audits for charts and billing during this time period. So if they're coming through and saying everything's going to be paid at the normal rate, and they will not be auditing charts or billing during this emergency part of the COVID-19. So we kind of put together some suggestions for your patient visits, things that we can look staff to selfly triage and manage patients that come into your office, making sure that your visual alerts are at your entrances on hand hygiene, respiratory hygiene, and cough etiquette, ensuring supplies are available like tissues, waste receptacles, alcohol-based sanitizers, having face masks available at triage for patients that have respiratory symptoms, and create an area separating patients with respiratory symptoms from your other patients, ideally that are greater than 6 feet apart in your waiting area. Measures for your staff members. Designate staff who will be responsible for caring for the COVID-19 patients. Advising your employees to check any signs of illness before they report to work and notifying their supervisors if they are ill, and keeping up with accurate inventory of your PPE and other essential daily supplies. This is going to be critical if you're running low on supplies. The resources to get these supplies is becoming very limited, and delivery systems have been very delayed. So we don't want our clinics running out of their appropriate supplies to treat these patients and have patients in the office that we cannot properly have PPE for. Instruct your patients to use available advice lines, patient portals, online self-service, self-assessment tools, or call and speak with an office before they come in if they are experiencing symptoms like fever, cough, or shortness of breath. Identifying staff to conduct these telehealth interactions with patients, developing protocols so the staff can safely triage and assess the patients quickly, and determine algorithms to identify which patients can be managed by the telephone, advised to stay home, and which patients need to be sent to an emergency care facility or come into your facility to be treated. Instruct patients that if they have respiratory symptoms, that they should call the office before they leave home so that the staff can be prepared to care for them as soon as they arrive. I know that there are many more things that we can do. This was just a quick overview of things that we thought were important as we move forward through this. So at this time, I want to go to our chat and see what kind of questions that we are having from everyone on the line. So one of the questions was, do we have tips for E&M coding and no physical exam and the level of care? So those will go into just like back, I'll go back to the slide here with your coding. For these visits, like I said, that if you have your start and stop times on these are going to be time negated. So each one of these visits, not only do you have the option to bill out based on time or bill out based on the bullet points of your examinations, because we cannot do physical exams, we cannot do vital signs on these patients. All of these codes will be time-based. So using the appropriate time-based code is how you would bill out for those E&M visits. Do you need to obtain consent for treatment via telehealth services? Verbal consent is all that's needed. You do not have to have a written consent, just verbal consent. Most of practices don't even realize that they have obtained verbal consent, even in their new patient paperwork. A lot of practices ask that question, if we can call you and leave you a voicemail in regards to your care. Can we send you a text message for reminders? A lot of providers that have patient portals, these are already done. But if the patient is calling you and making that initial contact to your office, as long as you have the verbal consent for that, you are covered. The question has been asked, since the COVID-19 test takes some time for it to come back, do we hold the claim until we have a confirmed test? You can. The testing would only confirm that they have the COVID-19, and the COVID-19 diagnosis would only be applied with patients that have the respiratory conditions of the pneumonia, bronchitis, respiratory infections, and the ARDS conditions. Otherwise, you would just go ahead and bill out their signs and symptoms. Is any diagnosis covered through telehealth or only COVID-19? All diagnoses are covered. They went ahead and expanded that out, that it does not have to be a COVID-19 sign or symptom, that all diagnoses are covered. That's the reason why they're allowing us to do the transitional care management and the annual wellness visits via telehealth. Telehealth visits for controlled medications for follow-up, that is covered as well. There is a link here, and we will send this link out from CMS on all the covered procedure codes that are available, and those are in there as well. Modifier GT versus modifier 95. The GT modifier is not needed. Medicare is not requiring any um, modifiers at this time. The only modifiers that would really need to be used is the 95 for commercial payers still requesting it. If you send the claim over on a Medicare patient with a modifier, they are not going to kick it out, but it's just easier to go ahead and use it on all of them. The only other modifier that is out there for this process is the GQ modifier, and that is for your asynchronous systems that are a like patient portal that have a store and forward feature, like using email, text messages, communications through the portal. All places of service will be place of service 2 for telehealth services. So if you have a patient that calls in and you're going to be treating them for their diabetes and hypertension, it would be the same as you would be billing out a regular office visit. It would just be using the place of service 02, and depending on what technology you're using, if you're using a patient portal versus a just real-time two-way audio of using that 95 modifier or a GQ modifier. Most practices are not going to use the GQ modifier. The 95 modifier is the modifier that most practices are going to be used unless you are sending it through a store and forward system. There are multiple telehealth systems out there that are available that will be sharing some of that information as we collect all of that. And as we go forward and learn more about those systems, we'll be able to give you more information on that. Yes, you would only use the COVID-19 diagnoses once it has been confirmed. Unless you know that they have had exposure, you would want to use the Z codes for the possible exposure or the confirmed exposure. Otherwise, the only time that you would use the COVID-19 diagnosis is after it has been confirmed. There is not a diagnosis for suspected. You just use your signs and symptoms. Reimbursement for these codes are going to be your standard reimbursement. They have not changed reimbursement for these codes from everything that we have read so far. It will be the standard reimbursements that we have set forth, that is set forth in the fee schedules for these patients. For the G2010 and 2012, I have not seen an official fee for that reimbursement on that one. I think because it is a temporary code that they just developed, we are watching out for the fee schedule for that. Yes, Medicare is covering the 99421 and through the 423. They are covering those services during this time period. The difference between the telehealth and the e-visit, the telehealth is you're just like you were to see the patient for a face-to-face visit. They call in, you do a sick visit with this patient. You would treat that just like it was a face-to-face visit. The e-visits are a cumulative time over a 7-day period and are done through an online patient portal. So that is the difference between those two. And there's no limit on how often you can bill these. I have not seen any documentation for prolonged visits for telehealth. I will look into that and see if there is anything, but at this time, there has not been anything published for prolonged visits for telehealth. Yes, the codes are the same for rural health clinics. We will be issuing out this, distributing out this sheet. Yes. Do the visits have to be video or can they be phone calls? They can be phone calls. The phone calls are going to be your brief check-ins, your 5 to 10 minute. For the telehealth services, it has to be an interactive audio video telecommunication system that permits real-time communication. So that would be any kind of video conferencing that you can have with that patient, whether it's a FaceTime, Skype, through a patient portal. There's several different other platforms out there, but it has to be a live, interactive, two-way audio visual communication for telehealth services. Otherwise, it would just be a phone call using the G codes. So the question is being asked on the virtual check-in and telehealth visit codes together. So for the virtual check-ins, those cannot originate and be billed out if the patient was seen or had an E&M visit for the same condition in the preceding 7 days or leads into an E&M visit within the next 24 hours. So if a patient calls in and you had a brief conversation with them, and then tomorrow morning they call back and their symptoms have worsened and you bring them into the office, you would no longer bill the G code, you would bill an E&M code. If they had previously been in your office 7 days prior and the patient was calling back in for a follow-up, that is globalized into that E&M code from 7 days prior. Yes, this session is being recorded and will be available later for viewing. Where does the place of service to show up on the on a 1500 claim form? It would be in the same place for your place of service 11 for office visit. It will just be a 2 instead of an 11. For recording your time spent on the patient in your e-visits, the e-visits is the actual time that you are online with the patient. It does not include any time for reviewing records or any of those things. That is strictly for the time on the video call. The 905 modifier is to be used on any visit, whether it's sick or well visit for your telehealth services. Can telehealth services be done on new patients? From what we are reading so far, yes, new patient visits are included in the list of approved telehealth services through CMS via this link that's listed above on the slide. Okay, I think we've covered all the questions. I know that there are several repeat questions in there for some that had come in later. Like I said, this session is been recorded and it will be going out to everyone. Is there any other further questions? Consent for patients is being done verbally. Yes, controlled medication follow-ups can be done through telehealth. All these codes here have to be done by a billing provider, the provider that has, just like if they were in your office, it would be just like they're seeing the doctor. It has to be done by the provider that is credentialed with the payer as the provider of service, being your MD, DO, NP, PA. For your virtual phone calls, it can be, you know, a nurse that's checking in with them on your 5-10 minute brief conversation. But if any decision making needs to be done, a provider has to be in on that conversation for that. In order to bill it out, it has to be done by a billing provider. Yes, non-contracting Medicare providers can use the G code. That G code is actually a temporary code and does not have any restrictions on it for non-par providers. Any other questions? I know this is a lot of information. I know we're all very, very stressed during this time, and we will be providing information as soon as we get it out to y'all if anything changes. And hopefully by Monday, we'll be rolling out our communication platform and have our websites updated to where you can go to our website, get the most recent and up-to-date information as we get it.
And we also are going to, for the next few weeks, be hosting webinars on Thursdays at noon. So if you have any questions, if you want to come, it's going to be us sharing what's new and what's been updated within the last week, and also for you to ask any questions to our clinical quality person, Crescent, our HCC coders, your PBEs, anyone that you have questions for. It'll be a forum for that as well. So we'll be doing that every Thursday. We'll send out invitations before that so that you can try to be on if you have anything that you need or any updates that we have to give you. And also, if you have any more questions from this presentation, please don't hesitate to reach out to Crescent or your PBE, and they will pass along the information. We will, when we send out the recording and the tip sheets, we'll include Crescent's email in case you do have more questions. And if we do get more questions, we'll send those out to everyone so that you have the answers to those in case you did need to know that. So thank you all for attending. Thank you, Crescent, for sharing your knowledge with all of us. And if y'all have anything else, please let us know. And we are here to help y'all with anything that you need. So please don't hesitate to reach out to us. And we'll share everything that we find out as quickly as we can.
Thank you, everyone.